The iPACK block, or interspace between the popliteal artery and capsule of the knee, is a regional anesthesia technique that's aimed at providing relief for posterior knee pain. It's essentially ultrasound-guided posterior capsule infiltration, and in this video, we'll go over the anatomy, sonoanatomy, technique, and tips and tricks for performing the iPACK block. Patients who undergo knee surgery have multiple sources of pain, and we spend a lot of time focusing on strategies for anterior sources, femoral or adductor canal. But an interesting thing happens when you block the anterior part of the knee. The back part, which the patient had been ignoring because of the anterior pain, suddenly becomes an issue, and we have ways to address that. Behind the knee joint is a fine meshwork of nerves called the popliteal plexus, originating mostly from the tibial nerve, but with contributions from the peroneal and obturator nerves as well. Blocking the popliteal plexus aims to provide posterior knee analgesia without any corresponding motor block of the lower limb. Here we see a cadaveric image of the web-like popliteal plexus largely deriving from the tibial nerve. We don't want to block the tibial nerve itself, just the sensory fibers that make up the popliteal plexus. Now, this fine mesh-like popliteal plexus lies in a fat-filled space between the popliteal artery and the knee capsule, and that's how we get the name. We're going to place a local anesthetic here. Here's a cut of the thigh just above the knee joint. We can see the distal femur, the popliteal artery and vein, and the sciatic nerve. We're going to advance a needle from the lateral aspect parallel to the metaphysis of the femur into the iPACK space. We'll go to the medial side of the space and then inject a local anesthetic as we withdraw, like you're filling a donut with jelly. With the probe placed on the posterior thigh just above the knee, we get this image: artery, femur, and the iPACK space in between. Note that we can't see the popliteal plexus, but you know it's there. This block can be done supine with the leg elevated, but our preference is to have the patient in the lateral position with the operative side up, which improves ergonomics, especially in heavy patients. To get the correct position on the back of the femur, the probe is positioned on the popliteal fossa and the artery and femur identified. Sliding the probe distally reveals the two femoral condyles. At this point, the probe should be slid proximally again until the humps disappear and the flat metaphysis reappears. Doing the block here ensures the popliteal plexus will be present over the knee capsule. This block is primarily done for patients undergoing knee replacement and has been shown to reduce pain in the back of the knee after TKA. Now, most studies show a small effect compared to the value of the anterior knee blocks, but that's to be expected. Some studies have also shown improved joint range of motion and walking distance with iPACK. This block has also been used for post-op pain and ACL repair. These are fine nerves and you don't need a high concentration of local anesthetic. We use 20 mL of 0.2% ropivacaine with epinephrine. There have been sporadic cases of foot drop with this technique, but most of these involve volumes higher than 20 mL or highly concentrated local anesthetics that diffuse over to the sciatic nerve components. Okay, so here's the technique. We first find the condyles and then slide proximally to find the nice flat femur. A block needle is advanced from the lateral aspect and directed across the iPACK space between the artery and the femur. Be careful not to contact the artery or the femur. Once the needle is at the medial edge of the femur and following negative aspiration, the local anesthetic is administered while the needle is withdrawn. The goal is to distribute the 20 mL evenly across the back of the femur. And here's some iPACK tips. First, while a linear transducer can be used, a curvilinear probe provides a wider field of vision and eliminates the need to chase the needle with the beam. This is especially true in large patients. Second, it's important to calculate the distance from probe to iPACK space and insert the needle accordingly. For example, if you see that the space is 4 centimeters deep to the probe surface, insert a needle on the lateral thigh at a point that corresponds to 4 centimeters deep. This allows a trajectory that gets to all parts of the iPACK space and safely keeps the tibial and peroneal nerves out of the line of fire. A needle insertion too close to the probe puts the sciatic nerve at risk and doesn't allow the needle to get across to the medial side in order to spread local across the whole of the femoral surface. Third, it would be convenient to do this supine with the lower limb frog-legged, since I'm already doing an adductor canal and genicular blocks in the supine position. And some do this quite successfully. The thing to keep in mind is that with the knee flexed, it's challenging to move the probe to capture the correct image. Lining the needle up in plane with the beam can also be challenging if there's a lot of soft tissue hanging over the beam, as we see here. And then there's this approach. Patient supine, probe on the medial thigh. You get a much different image. Femur, vessels, and the iPACK space have been rotated 90 degrees. The needle path will be quite steep, and there's incomplete visualization of the entire iPACK space. Not very satisfying. Did we talk about how satisfying this view is? Right. And lastly, yes, you can advance from medial to lateral too. Some advocate for this as a way to stay away from the sciatic nerve, and I get that, although the trajectory tips we shared earlier should keep you far away from it. If you are going to go medial, be careful of the saphenous vein. This is one of the reasons we advocate for the lateral approach. Patients and surgeons won't thank you for a big, ugly bruise on the medial thigh because you skewered the great saphenous vein.